Empagliflozin. And you were watching this program from the Facebook page of General Pharmaceuticals Limited and also from the YouTube channel of General Pharmaceuticals page. Learned audience, it is evident that type 2 diabetes is more than just a disorder of glucose metabolism, and SGLT2 inhibitors, a newer class of oral antihyperglycemic drug, is widely accepted worldwide for its beneficial outcome beyond managing high blood sugar. Among all SGLT2 inhibitors, empagliflozin has led to a paradigm shift in treatment of patients with type 2 diabetes, and it has opened a new horizon in terms of beneficial cardiovascular and renal protective features. Moreover, American Diabetes Association, EASD, and CDA also recommended the combination of empagliflozin and metformin as first-line treatment for the patients whose HbA1c level is more than 9%. So based on this evidence, we're going to arrange today's live webinar on empagliflozin metformin fixed dose combination, new horizon in type 2 diabetes management. So first of all, let me introduce today's keynote speaker, Dr. Shahjada Salim, Associate Professor, Department of Endocrinology and Metabolism, BSMMU, and Organizing Secretary, Bangladesh Endocrine Society and ASCVD chapter. Dr. Salim has keen interest in clinical research in diabetes and its complications, prevention of diabetes, obesity, osteoporosis, and he has more than 100 articles published in international reputed journals. So let's welcome Dr. Shahjada Salim as keynote speaker. We are also delighted to welcome our respected panel of experts. Today we have Professor Dr. A.K. Muhibullah, ex-director and professor in ICVD. He is also the president of Bangladesh Cardiovascular Society and vice president of Asian Pacific Society of Pharmacologic. We also have Professor Dr. Shamim Ahmed, ex-director and professor of nephrology, National Institute of Kidney Disease and Urology, and ex-professor and head of nephrology, Dhaka Medical College and Hospital. We have Professor Dr. Khan Abul Kalam Alisar, Principal, Dhaka Medical College and Professor, Department of Medicine, Dhaka Medical College and Hospital. Welcome to the program, sir. Dear audience, we are very much honored and privileged to have Professor Dr. Zafar El-Latif, Professor and former Director General Baden, as our honorable chairperson of the webinar. Welcome to the program, sir. Now, I'd like to ask for permission from today's chairperson, Professor Dr. Zafar El-Latif, sir, for starting the session.
Okay, you can start it.
Thank you, sir. Dear audience, if you have any question or query regarding today's topic, you can put it in the comment section in Facebook, and we will be discussing after the presentation session. May I now request today's keynote speaker, Dr. Shahjada Salim, for the keynote speech on today's topic, Empagliflozin Metformin fixed dose combination, new horizon in type 2 diabetes management. Dr. Shahjada Salim.
Thank you, Dr. Sadia. Am I audible?
Yes, sir.
Yes.
Yes, thank you. We have the chairperson, Dr. Zafar El-Latif sir. Probably he is the teacher of almost all endocrinologists in Bangladesh. But for me, he is the most important teacher in my endocrine life, and not only in the endocrine life, I feel immense obligation to him to be guided in every aspect in the field of endocrinology. We have eminent, most probably the most important eminent experts from the 3 different specialties. Professor Shamim Ahmed sir, he is not to me, most of the students passed from Rajshahi Medical College. Shamim Ahmed sir was the most favorite student, teacher of, to all students during his presence in Rajshahi Medical College, and we learned many things in nephrology from Shamim Ahmed sir. Muhibullah sir, Professor Muhibullah sir, very renowned endocrinologist, currently president of Cardiac Society, and I had present experience to work with him in NICBD. And Professor Khan Abul Kalam sir, probably he is the most favorite internist in the country, and I also like him as my teacher, favorite teacher from Rajshahi Medical College. So I think this is very powerful, heavy panel, and I am very much lucky to be with these 4 eminent professors to present my topic today. And the most beautiful part of this webinar, the learned participants, I am giving you the to think new things and the many questions you can arise, and the panel probably will satisfy your question. So the topic of today's discussion, Empagliflozin Metformin fixed dose combination, new horizon in the management of type 2 diabetes mellitus. Is it visible to you?
Yes.
Thank you. Type 2 diabetes mellitus is in the hike. Currently, we are passing through the COVID-19 pandemic, but before this, we were in the epidemic of type 2 diabetes mellitus declared by International Diabetes Federation since 2012. This presentation, you all know, the General Pharmaceuticals sponsored presentation, and I will cover the parts of the today's presentation as the prevalence of type 2 diabetes mellitus, pathophysiology, and the topic of discussion SGLT2 inhibitors and metformin, their pharmacokinetics and use in the type 2 diabetes mellitus, and at the end, the take-home messages. This is very much commonly cited slides from International Diabetes Federation. At the end of the 2019, in the 9th edition of the IDF Diabetes Atlas, they published that during this time, the adults starting from 20 to 79 years, in total, 463 million of this adult group had diabetes, and with the increased rate of 43%, at the end of 2045, the total number of patients with type 2 diabetes mellitus would be 700.2 million. And the increase rate is not similar. It's very depending upon the geographical regions of the world. We can see that it is most highest in the African region. One thing we should keep in mind that the 143% increase, this is not only the new case. This is the new case and newly detected case. In total, 143. Next to this African region, Middle East and North African region, the MENA region has 96% increase. Next to that, the Southeast Asian region, the region the Bangladeshi belong to, we had the third highest increase rate of diabetes, 74%. And more importantly, we can find that the European region has only 15% increase from 2019 to 2045. Where Bangladesh stands, we can see here. In the 9th edition of International Diabetes Federation Atlas depicted that Bangladesh had the 10th position in 2019, according to the total number of patients with diabetes, but the condition is deteriorating. They postulated that in 2030 and 2045, Bangladesh will have the 9th position, depending upon the total number of diabetes mellitus. So we should be very much keen in treating our patients with diabetes, not only diabetes, also other comorbidities. According to the same diabetes atlas, we can find that the huge number of patients with diabetes will have cardiovascular diseases. One important information is that around 68 to 75% patients with type 2 or type 1 diabetes mellitus have the mortality due to cardiovascular disease. So we have the frequency of different categories of cardiovascular diseases. The prevalence of cardiovascular disease during this time, it was any cardiovascular disease 32%, coronary heart disease 21%, myocardial infarction 10%, and stroke 7.6%. The impact, the increase will be coronary heart disease 160%, ischemic heart disease 127%, hemorrhagic stroke 56%, cardiovascular disease 132%, and year of life lost due to diabetes and cardiovascular disease at 5.8 years from the age of 50, 6.8 years from the age of 50 for women, and 5.8 for men. So we cannot compare the life expectancy loss by any other parameters. Now, very briefly, I am going to pathophysiological and the development of type 2 diabetes mellitus. Why type 2 diabetes mellitus develops in a person? Type 2 diabetes mellitus is a cumulative effect of insulin resistance and insulin secretory defect. Before developing type 2 diabetes mellitus, at least 12 to 15 years prior to development of type 2 diabetes mellitus, the patient has insulin resistance and it is going up. When patient has type 2 diabetes mellitus, at least 10 to 12 years before the development of type 2 diabetes mellitus, it is demonstrated in the UKPDA study that the patient has declined insulin secretion. So we can see here that the insulin resistance has gone up. Insulin secretion primarily to respond to insulin resistance, if the pancreas is capable of producing excess amount of insulin, there will be hyperinsulinemia, but very soon the pancreas will not be able to cope up with the insulin resistance and insulin secretion will decline and patient will enter in the pre-diabetes, then diabetes. According to same graph, we can see that initially there will be postprandial hyperglycemia followed by fasting hyperglycemia. But again, very important thing to remember that the insulin effect will also decline. So the patient will have a high level of insulin resistance with increasing level of postprandial and preprandial blood sugar with decline insulin level and inhibiting effect. And this will continue. The postprandial blood sugar will go to the sky, and next to the postprandial, the fasting blood sugar, but the insulin level will tend to go to the zero level along with the inhibiting effect. So this is the chronological graph. But again, the very commonly cited the ominous octet, the multiple complex pathophysiological abnormality in type 2 diabetes mellitus. This is very much pertinent to recall for the management of diabetes mellitus to accommodate it with the pathophysiological changes that occurred in the patient with type 2 diabetes mellitus. This is a pancreatic beta cell dysfunction to produce insufficient insulin. Not only that, one thing we very often forget that the patient with type 2 diabetes mellitus, the pancreatic beta cell dysfunction is there, but the pancreatic alpha cell almost intact. So there will be unopposed activity of pancreatic alpha cell producing glucagon. The same effect will also be observed in the other parts. The insulin resistance will decrease the inward transport of glucose in the peripheral tissues, especially in the muscle and adipose tissue, and that will initiate excess amount of excess rate of gluconeogenesis from the liver. Behind all these steps, brain will be the main player. Not only that, but gut have the immense effect. So the gut hormone should be addressed, and not only the gut hormone, kidney is also very much important. Today we will try to focus on that part. So depending upon the pathophysiological impact of type 2 diabetes mellitus development, many of the drugs have been developed targeting every pathophysiological abnormality. We can see that insulin to replace the insulin deficiency, glutamate and sulfonylurea to secrete excess insulin, the glucagon antagonist, amylin mimetics has been there. The thiazolidine will decrease the insulin resistance in the peripheral tissue. Metformin is also more important one. That will also decrease the insulin resistance and decrease the gluconeogenesis from the liver. Bile acid secretion can be used to decrease the gluconeogenesis from the liver. Alpha glucosidase inhibitor, GLP-1 receptor agonist, and DPP-4 inhibitor all has the effect on the gut hormones. Now, today's topic of discussion, one of them, the SGLT2 inhibitor. I am coming in details with that. So this is the new dimension, decreasing glucose from the patient's blood without handling the pancreas. This is a new concept. What is the basic principle of the concept? Glucose is reabsorbed from the kidney tubule, around 90% from the loop of Henle. This is the proximal part, and distal part in about the 10%. And this is sodium glucose co-transporter dependent reabsorption of glucose. So if one person has the antagonist activity against the SGLT2 or T1, that will decrease the reabsorption of glucose. So this glucose will go excrete through urine, So this 90% of the 90% of total glucose reabsorption can be inhibited by sodium glucose cotransporter inhibitor, and 10% by sodium glucose cotransporter inhibitor 1. But one thing for diabetes patient is important that the 180 milligram, the renal threshold, this can be increased by threefold, 420 to 600 milligram in patients with diabetes, because there is a progressive decline of glucose supply to the cell. So the cell will accommodate to have the sufficient glucose. So when the reabsorption is inhibited, the huge amount of glucose will be inhibited to reabsorb from the kidney tubules. Several effects are there. I am not going to in details. I am coming to the important effects of the SGLT2 inhibitor. It will increase insulin sensitivity in muscles by increasing glucose translocation and insulin signaling. It will insulin sensitivity in the liver will be decreased by glucose 6-phosphate dehydrogenase deficiency. Gluconeogenesis will be decreased by decreasing Cori cycle and PEP carboxykinase, and improved beta cell function will be also observed in patients with SGLT2 inhibitor users. The total effect that has been provided by use of SGLT2 inhibitors are shown in that table. It is the huge table. I am coming the most important one, the direct metabolic effect, that it will also not only increase the excretion of glucose and decrease the glucose from the body, but also it will also increase the activity of glucagon. The cumulative effect is the increased glucosuria, decreased HbA1c, decreased glucotoxicity, decreased insulin resistance, decreased body weight and visceral adiposity, increased uricosuriya, decreased oxidative stress, decreased inflammatory markers, and vascular dysfunction. Oxidative diuresis will be there. Every molecule will go out, which also accompany with the sodium, one molecule of sodium and water. So there will be osmotic diuresis and natriuresis that will increase erythropoietin levels, increase hemoglobin and hematocrit, increase tissue oxygen delivery. It will also decrease the plasma volume, intestinal fluid volume, blood pressure, vascular stiffness, preload and afterload, vascular congestion, and cardiac wall stiffness. That everything will increase the cardiac efficiency. The direct renal effect, that initially we are very much doubtful that the increased level of glucose excretion may have the deteriorating function on kidney glomerular membrane. But study found that the glomerular pressure will decrease, albuminuria will decrease, renal growth and inflammatory marker will go down, and restore the tubular glomerular feedback and inhibition of NAC3 activity. So preservation of the renal function by decreasing progression of albuminuria and decreasing osteogenesis of the nephropathy. So it is nephroprotective drug. We can find that. A direct cardiac effect that can be observed, that the metabolic shifting, it will decrease the free fatty acid oxidation, increase glucose oxidation and BAE/OB oxidation, and increase P/O ratio, and the inhibition of NHE1 activity and decrease cardiac hypertrophy and fibrosis and hemorrhaging. That in total it will increase the cardiac efficacy. So the study results I am coming in details later on, but it can increase the 3-point cardiac events and increase heart failure in the patient. So it is also cardioprotective in the patients with type 2 diabetes mellitus. The pharmacokinetics of 3 SGLT2 inhibitors. Currently, there are 4 or 5 SGLT2 inhibitors available in the other parts of the world, but in Bangladesh we are having 3: the Canagliflozin, Dapagliflozin, and Empagliflozin. Bioavailability of Canagliflozin is about 65%, Dapagliflozin 62%, and Empagliflozin more than 60%. Peak plasma time 1 to 2 hours for Canagliflozin, 2 hours to 3 hours in Dapagliflozin, and Empagliflozin for 1.5 hours. Protein binding 99% for Canagliflozin, 91% for Dapagliflozin, and 86.2% for Empagliflozin. Volume of distribution 119 liter for Canagliflozin, 118 for DAPA and 73.8 liter for empagliflozin. Half-life, this is important, 10.6 to 13 hours for canagliflozin, 12.9 for dapagliflozin and 12.4 for empagliflozin. What glycemic effect we can observe in a patient with type 2 diabetes mellitus who is using the SGLT2 inhibitor? So if we compare the with the monotherapy of empagliflozin with add-on to metformin, add-on to pioglitazone, metformin, we add-on to metformin sulfonylurea, add-on to basal insulin. Very fascinating result. We can see that the monotherapy group that has used the empagliflozin, the reduction of fasting blood sugar with 10 milligram, it was 13.20 milligram per TL. It is about 1.73 millimole per liter, and 25 milligram 36.2, that is about 2.01 millimole per liter. So it is very prominent effect on fasting hyperglycemia reduction. What about the postprandial? We can see that the postprandial hyperglycemia reduction, it is more than by the 10 milligram over the 25 milligram, and the according to comparing with the placebo, the difference is very significant. And very importantly, we usually glycemic effect is observed in the clinical practice by HbA1c. The HbA1c reduction with monotherapy add-on to metformin and metformin sulfonylurea, we can see that with monotherapy it is 3.7%, with metformin it is 3.23, with sulfonylurea it is 2.89. So what are the study results? Several studies have been finished and several studies are ongoing. I am coming with a very important one, the EMPA-RACE trial, the one of the most important landmark trials that has been conducted in the field of type 2 diabetes mellitus. It screened more than 11,000 patients, and 7,020 patients have been randomized, and more than 97% completed the trial. This was a placebo-controlled randomized trial, and it has been conducted in many countries with the multi-center fashion. The baseline characteristic of the study participant was more than 50% had the type more than 10 years of diabetes duration. More than 25% has less than 60 millimole per 1.73 meter square of body surface area. Around 93% patient has albuminuria. 99% patients had pre-existing cardiovascular diseases. Among them, more than 75% had coronary artery disease, more than 46% had history of MI, around 10% had heart failure. Background standard of care therapy, this is American Diabetes Association standard of care of management of type 2 diabetes mellitus. Around more than 48% patients were receiving insulin, more than 80% received ACE inhibitor or ARB, more than 76% were on statins, and around 89% patients received antiplatelet agents. The fascinating result that has been found in EMPA-RACE trial, you can find there's 3-point MACE disease, the non-fatal MI, the ischemic unstable angina or cardiovascular death. This decreased relative risk reduction was 14%, and absolute risk reduction 1.6%. CV mortality reduced, relative risk reduction by 38% and absolute risk reduction by 2.2%. Hospitalization for heart failure reduced by 36%, absolute relative risk reduction, and absolute risk reduction by 1.4%. Hospitalization for heart failure or CV mortality, relative risk reduction by 34% and absolute 2.8%. Incident or worsening nephropathy, relative risk reduction by 39% and absolute risk reduction by 6.1%. More than 40% sustained decline in GFR, relative risk reduction 45%, absolute 1.4%. All cause mortality reduced by 32%, relative risk reduction, and 2.6% absolute risk reduction. Around 1 hour prior to this program, very recently, this Frontiers Diabetes Frontiers in Medicine published this review article. This study compared the risk of renal outcomes among patients with CKD treated with SGLT2 inhibitor. They compared the results of 10 studies. I am only reading the most important one, the Empress trial. We can see that the improved of incidence or worsening of nephropathy. The result I have shown you that the Canvas study that found that the canagliflozin was also associated with a lower rate of progression of albuminuria. The Declare TIMI 58 study, the incidence of the renal composite outcome was 4.3% in the dapagliflozin group and 5.6% in the placebo group. The Artis CB study, the renal composite outcome was 3 versus 3.9. So this is also important. The Credence study, the ESRD, a doubling of serum creatinine, renal or cardiovascular death for canagliflozin versus placebo was 43.2 versus 61.2 per 1,000 patients. So several studies also have the similar results. So I'm not reading all the study results. Now, what is the place of type 2 management, type 2 diabetes management and SGLT2 inhibitors? The most robust guideline currently in practice in many parts of the world, including Bangladesh, we can find that the patients who have the type 2 diabetes mellitus, the lifestyle modification and metformin is the first line therapy, pharmacotherapy. Then patients who have the high risk of cardiovascular disease or cardiovascular event, for those patients, ASCVD or indicators of high risk of cardiovascular disease, for those patients, GLP-1 agonist or SGLT2 inhibitor is the preferred option. But if the patient is having a heart failure, particularly reduced ejection fraction heart failure, for those patients, SGLT2 inhibitor is the preferred one. Patients who have the CKD, for those patients, if eGFR more than 30, for SGLT2 inhibitor is the preferred drug to start with. But if the patient is a compelling need to minimize hypoglycemia, for those patients, along with DPP-4 inhibitor, GLP-1 agonist, hydrogenation, SGLT2 inhibitor is also important one. But if the patient is having compelling need to weight loss, so for those patients, the most important one is the GLP-1 agonist, along with lifestyle modification, but SGLT2 inhibitor is also important one. So the very important position, but the paradigm shift of guideline of using SGLT2 inhibitor has been made by 2019 European Society of Cardiology guidelines. They said that the patients who are having the high risk of cardiovascular event or had the cardiovascular event, for those SGLT2 inhibitor with the lifestyle modification with the primary drug. But if the patient is having BMI more than 30 kg per meter square, for those patients, metformin can be used. So the robust indication of SGLT2 inhibitor in type 2 diabetes mellitus, we can find that the overweight or obesity, hypertension, atherosclerotic cardiovascular disease predominant patient, heart failure or CKD predominant patient, compelling need to minimize hypoglycemia, contraindication to other drugs or intolerant to other drugs. So there are several other indications as well. But while using a drug, we have to very much cautious, especially in patients with DKD, according to AD and other recommendation. If the eGFR is above 30, we can use the drug, but if it is below 30, we should not use. At the end of the May 2021, a very good review article published in the New England Journal of Medicine. They have compared all drugs that has been in use to treat diabetes mellitus and the property of those drugs to reduce the cardiovascular mortality, starting from the primary or secondary endpoint. We can see that with the primary endpoint, the empagliflozin and canagliflozin meet the primary outcome and secondary outcome, and dapagliflozin primary outcome, and orforgliflozin, this is not available in Bangladesh, at the secondary outcome of cardiovascular outcome in their studies. So the multiple cardiovascular disease risk factor reduction, that has also the empagliflozin and dapagliflozin has the similar study outcome. Another heart failure with reduced ejection fraction, DEPA and empagliflozin has the primary outcome. So the convincing result we have observed in several studies. Albuminuric chronic kidney disease patients, the canagliflozin and dapagliflozin has the secondary outcome and primary outcome, and they achieve the outcome that the study has a convincing result to use these drugs to reduce the albuminuric chronic kidney disease progression. So again, adversity to genital and urinary tract infection. When the drugs came in market, there is suspicion by the physician that can increase the chances of having urinary tract or genital infection, but several studies found that there is no statistical significant association with that. Even then, we should be very much cautious. The patient should practice good personal hygiene. Patient should consume adequate water, and the patient, if is having several episodes of urinary tract infection, we should not start the drug for those one. Another, the volume depletion, as the glucosuria along with water will cause volume depletion. So the patients who are using this drug should be advised to take adequate water, and the patients who are using the diuretics along with the other antihypertensive drugs, the diuretics part should be stopped. This effect will be provided by SGLT2 inhibitors. Now, another fascinating drugs to be used in type 2 diabetes mellitus or in other occasions. I am coming to this one, the metformin. The metformin is the first-line pharmacologic treatment for type 2 diabetes mellitus, the most commonly prescribed drug in the many parts of the world. It is used either alone or in combination with other drugs. It is in use since 1957, starting from France, and has more than 73 years of clinical experience. It was the fourth most commonly prescribed medication in USA in 2019, and with more than 80 million prescriptions alone. So what does metformin do in the body? It inhibits the mitochondrial respiratory chain complex 1. It activates the AMPK kinase activity. It also decreases the glucokinase activity and gluconeogenesis from the liver, and it also stimulates peripheral utilization of glucose by muscle and adipose tissue. So it also has an insulin sensitizing effect with multiple actions of tissue, including liver, skeletal muscle, endothelial adipose tissue, and ovary. Average patient with type 2 diabetes mellitus has 3 times the normal rate of gluconeogenesis, and metformin treatment reduces this by over 1/3. Metformin exerts direct beneficial effect on beta cell function such as insulin release, transcriptional regulation in pancreatic islets, and islet cell viability, being dependent on the presence of glucose. It can effectively avoid hypoglycemia. Several studies found there the metformin has the dominant cardiovascular protective effect. This is UKPDA 34, the Coe et al., Presto et al., Johnson et al., Uric et al., Evans et al., and this registry all study found that metformin has the important effect to reduce macrovascular, and in the long run cardiovascular death in the patients with type 2 diabetes mellitus. So how we can use the pharmacokinetics of this drug? It is taken orally, absorbed through GI tract, not metabolized at all, and excreted unsensed in the urine. So concern of renal function is there. So metformin indications in type 2 diabetes mellitus to reduce insulin requirement in patients who are requiring high volume of insulin used to address the good glycemic control, and can be combined with all the drugs used in type 2 diabetes mellitus management. It can be also used in polycystic ovary syndrome to reduce insulin resistance, but very importantly, it is one of the important ovulation induction inducing drugs. Certain malignancies has the indication to use to reduce, especially in colorectal carcinoma, breast carcinoma, and many more. So while using, we should be very much cautious about the adverse effect, which is not very infrequent. Around 10 to 15% patient may have adversity, and around 6% patient may not tolerate. The adversities are anorexia, nausea, vomiting, diarrhea, metallic taste, loss of weight, skin rashes, lactic acidosis. It is almost a theoretical problem. Very rarely you can find in the clinical scenario. And the chronic use of vitamin metformin can cause vitamin B12 deficiency. So if any patient is having symptoms of peripheral neuropathy, for those patients, the ADA recommendation is to measure vitamin B12 status, and vitamin B12 supplementation may be needed. So for addressing this patient, we should start low dose and escalate dose depending upon the patient response. And contraindication, the well debated area is renal failure. So the current statement from American Diabetes Association, if the patient is having eGFR more than 40, full dose of metformin can be given. And if their eGFR fall between 30 to 45, half of the maximal dose can be given. But if the patient is having acute or advanced liver disease or gut disease, in this time we cannot use this one. For alcohol abusers, the drug can cause even hypoglycemia. During pregnancy, we cannot start this one. And acute gut-related problems, during this time, we should not use the drugs in type 2 diabetes mellitus. Now, coming to the combination, these two most beautiful drugs in market, we can combine to have the beneficial effect. What are the evidences? The initial combination of empagliflozin and metformin in patients with type 2 diabetes mellitus. This is study published in Diabetes Care by Sami Haddad. They had the objective to compare the efficacy and safety of initial combination of empagliflozin and metformin with empagliflozin and metformin monotherapy, and they came out with these brilliant results. We can find that the patient who received metformin alone at a dose of 500 milligram twice daily, the HbA1c reduction was 1.18%, and for 1000 milligram twice daily, it was 1.75%. Patient who used empagliflozin 10 milligram once daily, the reduction of HbA1c was 1.35, and for 25 milligram 1.36. The patient who had the combination of metformin and empagliflozin, 5 milligram empagliflozin and 500 milligram metformin twice daily, the reduction of HbA1c was 1.98. For 500 milligram and 1000 milligram metformin, the reduction of HbA1c was 2.07%, and 12.5 milligram and 500 milligram metformin, it was 1.93, and 12.5 milligram and 1000 milligram metformin twice daily, it was 2.08. Huge reduction of HbA1c was observed in the study. And more importantly, the reduction of HbA1c was stable for patient who received empagliflozin metformin combination, comparing with the patient who received metformin alone. Now, another component, there are several components of the study. I am coming with the very important components. The change in the body weight, we find that with metformin, the reduction of body weight was 0.5 by 500 milligram twice daily, 1.3 kg by 1000 milligram twice daily. Empagliflozin 10 milligram reduced 2.4 and 25 2.4, and empagliflozin metformin 5 milligram over 5 milligram plus 500 milligram metformin reduced 2.8, 500 milligram and 1000 milligram metformin twice daily, 3.5 kg. 12.5 milligram empagliflozin, 500 milligram metformin twice daily, reduced 6 kg. And the most beautiful and most important findings of with the 12.5 milligram and 1000 milligram metformin, this was 3.8 kg over the 24 weeks of study duration. And again, the weight reduction was stable with the empagliflozin metformin than metformin alone. And the comparison of the side effects with empagliflozin metformin combination, empagliflozin alone and metformin alone, there was no significant adversity observed in the study. So this study concluded by saying that empagliflozin and metformin for 24 weeks significantly reduced HbA1c versus empagliflozin once daily and metformin twice daily without increasing hypoglycemia, reduced weight versus metformin twice daily, and were well tolerated. So at the end, we can say that the combination of empagliflozin metformin in a fixed dose fashion in a single tablet can be useful to treat patients with type 2 diabetes mellitus who are inadequately controlled with metformin and need to progress to dual therapy, and this option may be particularly suitable for patients who would benefit from additional benefits of modest BP and weight reduction, as well as individuals with risk of cardiovascular disease and declining of renal function. The single pill combination could also simplify therapy and potentially improve clinical outcomes compared with co-administrations of individual tablets. So the patients who are having diabetes, hypertension, or other cardiovascular diseases or obesity, they are on several drugs. So if we can combine several drugs in a fixed dose combination, that will reduce the number of drugs. That will similarly increase the compliance by the patient. That will again have the good outcome of the patient in the terms of glycemic control, weight reduction, and cardiovascular protection. So thank you all for your patient sharing. As we are in the probably third wave of COVID pandemic, so stay home, stay safe, and at the end, I also very much grateful to you all for serving the patient, and I bestow my esteemed respect to the physicians and other health workers and the persons who dedicated their works and sacrificed their life for the management of COVID patient in the world. Thank you all. Dr. Sadia, unmute.
host connected হচ্ছে না।
Thank you, sir, for this presentation. Now the
সাদিয়া আপু শোনা যাচ্ছে না আপনার কথা?
Network problem.
স্যার শোনা যাচ্ছে?
হ্যাঁ শোনা যাচ্ছে, বলেন।
টেকনিক্যাল সমস্যা হচ্ছে মনে হচ্ছে।
Thank you very much, sir, for your nice presentation.
আচ্ছা, হোস্টের যদি অসুবিধা হয় তাহলে আমরা বলে ফেলি।
স্যার ওই সেলিম স্যার কন্টাক্ট করলে ভালো হয় মনে হচ্ছে।
আমার মনে হয় জাফর স্যার চেয়ারপারসন স্যার আপনি
জাফর ভাই আপনি শুরু করে দেন, শুরু করে দিয়ে বললেন আমরা বলা শুরু করি।
নেটওয়ার্ক কন্ট্রোল করতে প্রফেসর জাফর লতিফ ভাই আপনি এটা কন্টাক্ট করেন।
আচ্ছা ঠিক আছে, আমি শুরু করি। ডক্টর শাহজাদ সেলিম এক্সপ্লেইন করেছে খুব সুন্দরভাবে এন্টায়ার ডিজিজ স্পেকট্রামটাকে। আমি এক্সপার্ট ওপিনিয়নের আগে এই রোগটা সম্পর্কে I want to say something about the disease itself. Diabetes is a multifactorial disease, not a single disease. There are so many factors are involved. But whatever factors it may be, ultimately it is the insulin and insulin sensitivity is the main culprit. In a physiological condition, the amount of insulin secreted in our system is not there when there is diabetes. At the diagnosis of diabetes, about 50% beta cell is exhausted. This is number one. So, natural history is that whatever treatment modalities that we used to give previously, used to work for 3 to 5 years as proved by UKPDS study. After 3 to 5 years, every patient needs insulin. That was the problem because beta cell exhaustion. We stimulate the beta cell by sulfonylurea, by glenide, or so many other things. So now the question is that if you can do something which will prevent the delay of beta cell exhaustion, number one, or beta cell can be regenerated again to a physiological condition. This is two condition. Next question is that when there is diabetes, already the patient is having diabetes, so many studies, including UKPDS, DCCT, Kumamoto, and many other disease studies proved beyond doubt by good glycemic control, microvascular complication can be curtailed to a significant number, but not macrovascular disease. That is only 16% proved in UKPDS study. There is improvement there. The macrovascular disease, that means ischemic heart disease, is a multifactor. Again, it is not the diabetes alone. We shall have to take care of other factors as well. So, and the third one is the cardiovascular disease is the major killer of diabetes mellitus. A patient doesn't die of kidney disease in that much, maybe not more than that of a normal non-diabetic person, but alarmingly, more than 100% or 130, 50, 60% death are due to diabetes in cardiovascular disease in diabetic patient. So keeping this to, if you think in mind, if we think that the major killer and of diabetes is ischemic heart disease, and we can save the beta cell from total exhaustion. How can I do that? First one is that if we don't stimulate the beta cell, if we can sensitize more the available insulin in the system, how can I sensitize it? We can sensitize by preventing, by prescribing metformin, which causes reduce the insulin resistance. So by reducing the insulin resistance of the available insulin in the system, beta cell is less stimulated. This is number one function of metformin. Last one is that if I can drive away the excess sugar into urine, so that will not also stimulate beta cell. So beta cell exhaustion will be delayed by metformin as well as SGLT2 inhibitor. So beta cell will be preserved for longer period of time. If we can save the beta cell for the longer period of time, the need of insulin will be delayed. Otherwise, most of the patient, as I said earlier, need insulin in 3 to 5 years time, or maybe 5 or 6 years time, or 7 years time, they need insulin for their circulation. So as it is a multifactorial disease, insulin resistance, kidney is involved, liver is involved, so many factors are there. And there is, I say already 8 factors, octet, ominous octet. So by prescribing metformin and SGLT together, we are not stimulating beta cell. So maybe some of the beta cell function may be regenerated, or if not regenerated completely, the exhaustion of beta cell will be delayed. That is one of the achievement. And simultaneously, Dr. Shahjata showed clearly the SGLT2 has other advantage of lowering blood pressure, lowering dyslipidemia, lowering body weight. All the metabolic component of cardiovascular diseases are being taken care by metformin and SGLT2. So this combination is a very good combination, and I think that will be very helpful definitely in a very significant group of patients. Thank you very much, Dr. Salim, for your presentation. Now I shall request Dr. Muhibullah to say something about, comment about the presentation.
Respected chairperson and the honorable faculties, by this time our speaker very nicely and elaborately explained the informative presentations, as well as the chairperson has explained most of the things by this time. I have I have to say that the type 2 diabetes mellitus is increasing throughout the world, including Bangladesh, and it has an increasing risk of macro and microvascular complications. Moreover, it may produce myocardial dysfunction and ultimately heart failure, even in the absence of the other risk factors like hypertension, coronary artery diseases, and this special entity is known as diabetic cardiomyopathy. And it has been found that the use of empagliflozin in type 2 diabetes significantly improves the arterial stiffness and vascular resistance in addition to control of diabetes mellitus. It has been beneficial effect in myocardial oxygen consumption, which ultimately reduces the ventricular wall tension. It also reduces blood pressure, which in other way reduces cardiac workload. So we can conclude that the use of empagliflozin is effective in improving cardiovascular complications as well as in controlling the type 2 diabetes mellitus. I am very much thankful to the chairperson and the faculties and the General Pharmaceuticals for inviting me here in this webinar. Thank you. Thank you very much to you all. Thank you once again. Sir, I have a special work in the country. Sir, I have a work with my family, so I have to leave now. Thank you very much, sir, if you permit.
Okay, thank you.
Thank you very much, sir.
Thank you, sir.
Thank you.
Can I hear from Dr. Khan Abul Kalam Azad, please?
Okay, sir. Thank you very much, sir. My respected teacher, Professor Jafar Al-Latif, is not only the teacher, but you know that when endocrinology was, in embryo, and at the time, people understanding, or the understanding by the doctors, the students, was, not too much, at the time, Professor Jafar Al-Latif, I found him that he is moving from one medical college to another and explaining the details of diabetes mellitus at the time. At the time, I completed my FCPS examination, but I should confess that even at that time, I was not very much rich about diabetes mellitus because many information were coming in about diabetes mellitus. We were knowing diabetes mellitus, and really we saw that it's an ocean. So at the time, Professor Jafar Al-Latif sir was very kind enough to move from one place to another to teach the students about diabetes mellitus, and he's chairing the session. I like to say my respect to my great teacher, Professor Jafar Al-Latif. And also we found two great teachers of the country. When cardiology was, a very small subject at the time, Professor Mohibullah, he was talking a little earlier, and he was there to make cardiology a real subject. And today we understand that what cardiology means. Whenever you talk about a medical illness, it means cardiology should be there. And the second organ, that is your kidney, Professor Dr. Shamim, also when we found that there was none in nephrology to treat patients with having huge number of patients with renal problems, either primary or secondary disorders. At the time, Professor Shamim and other teachers were there, and they became the teacher of the subject. So I'm very much pleased and very happy, and I feel honored to be with these great teachers, all these three teachers in the same platform. And to talk about today's speaker, Dr. Shahzada Salim, he is really a silent observer, but his brain was so sharp, and the way he started studying the things, and a very good researcher. He has got so many questions in his mind, and he is a very good presenter. And I attended several presentations of Dr. Shahzada Salim, and today it was an excellent presentation. So much evidence-based that I have truly say that Dr. Shahzada Salim has really made this program a very successful one. And the presence of these three teachers it means that the program should be a very effective one. And the evidence-based, talking of Dr. Shahzada Salim made it possible. And really, it glorified the session by Dr. Shahzada Salim. And also, I'd like to give thanks to General Pharmaceuticals for this scientific endeavor when I was invited. And really, I'm very, honored. I feel privileged to be here in such a webinar. To talk about the issue is that the background for choosing this topic was described by our Honorable Chairperson, Professor Jafar Latif, that what diabetes is, what insulin is, and what the oral anti-diabetic agents are, and how to save the pancreas, how to work in other ways. And so that, and as Dr. Shahzada Salim showed the different drugs which are working. And to talk about this one sentence made by Professor Jafar Latif in one of the sessions, he said, insulin is the best treatment and other forms of treatment may be needed. And we understand that type 1, it is the insulin. Type 2, after exhaustion of the pancreatic beta cell, you may need insulin within 3 to 5 years. And so that treatment is insulin. But in our country, and also in some other countries, we see that insulin treatment may be unsuccessful. Why? Because of so many reasons, that people, they do not like to make a puncture into the skin. They don't want to store the insulin in proper site. And once insulin is finished, they take several days or months even to procure new insulin. And also may not be that desired insulin is available everywhere. And also requiring high amount of insulin and prescribed by the doctors may make the patient unhappy and he is reluctant to take insulin. And also the route is important and the people like to take orally. So for these reasons, oral anti-diabetic agents are the preferred one in most of the diabetic patients, and also the doctors, they like to prescribe in most of the outpatient patients without any complication. And because we know that anti-diabetic agents orally also, they have got many potential beneficial effects, especially the cardiovascular outcome and also the renal outcome. We need all these anti-diabetic agents. So here, the topic was that metformin and empagliflozin. We understand that metformin, when we were the students, metformin was a little bit neglected. Everybody used to say, okay, there may be lactic acidosis. But truly speaking, also another sentence from Professor Dr. Jafar Latif, he never saw any lactic acidosis after metformin. So lactic acidosis from your sepsis or some other thing are far more common than after taking your metformin. So we understand afterwards how popular this metformin became to reduce the side effects of your diabetes mellitus and also to control blood glucose adequately in diabetic patients. So metformin and then the SGLT2 inhibitors, after the approval by FDA in 2014 or like that, so we found that there is greater involvement of SGLT2 inhibitors in treating diabetic patients. So when you combine this together, we need a very good diabetes control. We need a very effective compliance from the patient. And we need a very good cardiovascular outcome. And we need a very good renal outcome. And also, we don't want to exhaust the pancreas. And also, it should be cost effective. So if we consider all these things together, so definitely, as Professor Jafar Latif sir described, that without exhausting the pancreatic beta cell, we need some very good combination. So what I believe that empagliflozin and metformin combination, as it is well described with evidences by Dr. Shahzada Salim, I also say that yes, it is a very good combination regarding the patient's side, the doctor's side, and also there are more and more scientific evidences. So what I believe that today's explanations from Dr. Shahzada Salim will help with enable the physicians who are listening to this presentation to choose to select an anti-diabetic combination, especially when they are selecting a non-insulin therapy in such a way that it can help the patient. So it was again a wonderful session. I am very privileged, and also I like to pay my respect to Professor Dr. Zafar Latif, Professor Dr. Shamim Ahmed, and also Professor Dr. Mohibullah. And also I like to say Dr. Shahzada Salim, okay, I need more and more presentation from you, and also more and more researchers in the field, so that we can get something new in the future. So, and also again, thank you everybody who are listening to the program. Assalamu alaikum. Good night.
Thank you very much, Khan Azad. Now I request Dr. Shamim Ahmed to comment about this presentation. Dr. Shamim Ahmed, please.
Thank you, the chairperson, Honorable Professor Dr. Jafar Latif, former director, BARDEM, and the Professor Mohibullah, former professor and director, NICVD, and Professor Khan Abdul Kalam Azad, ex-principal and professor, and also the speaker, Shahja Salim. I think the speaker, the chairman, is the senior most person among us, and he, he's a dynamic person. We know him very well, as already described. Professor Principal of Dhaka Medical College is a dynamic person, and he has a lot of contribution in a diabetic. Today's topic is very important, not from cardiovascular point, not only cardiovascular point, not from diabetic point of view, but renal point of view. Because, initially we had been taught that glomerulonephritis is the first cause of CKD or end-stage renal failure. And nowadays we say that it is the most important cause is the diabetic mellitus, because it is the first cause. It is epidemic form. Before starting my opinion, I must say Shahzada Salim is an excellent speaker, and we are proud of him. From Rajshahi, I know him very well. He first called me to be present, and so I'm very grateful and thankful to him that to inviting. And I must say to the Professor Muminul Haq, the managing director of the Channel Pharmaceutical. I don't know whether he's seeing this. We are a good friend in Dhaka Medical College. A long time we have no face-to-face contact, but he is a very good human being, amicable person, and he's is a managing director of a great pharmaceutical, General Pharmaceutical, and also high official of General Pharmaceutical for inviting in this one. Now coming to the point of discussion, as you know, today's topic is only because I'm not going into details Empagliflozin and Metformin, because Shahzada Chaudhary has given a details of Empagliflozin. We had been in ASN, American Society of Nephrology in San Diego, where we the first this sodium glucose co-transferase inhibitor, I think 2017, and also in the Melbourne. So this drug was coming is 5 or 30 years. Nowadays is a very good drug, as you know. Now let me concentrate on the drug they want to highlight. What is the drug? It is sodium glucose co-transport inhibitor. This is the drug that in the tubule, you have to know this afferent arteriole, which is the branch of interlobular artery, renal artery branch, and the tuft of capillaries and the efferent arteriole. I just go to, as I'm kidney man, I must explain. I think there are 44 participants. So this is afferent arteriole, the tuft of capillaries, and efferent arteriole. Why I'm telling, let me say. So this glucose co-transporter, sodium glucose transporter, the transporter 2 and 1, as I said rightly, 90% glucose is absorbed in proximal tubule and 10% distal tubule. So what happens in case of diabetes? There is the abnormal glomerulotubular feedback mechanism. As you see, there is a hyperglycemia and hyperfiltration, and there is an injury of the kidney. In fact, kidney is damaged because of increased interglomerular pressure. And how these drugs help? So whenever there is a hyperglycemia, this afferent arteriole is dilated. Why? Because of defect in tubular feedback mechanism. So there is sodium is less. Why? The most of the sodium and glucose is absorbed in the proximal tubule. Less sodium is distal tubule to have an action on macula densa. So there is a less sodium. Now, what happens when we use these drugs? So they block this sodium glucose co-transporter. So less sodium and less water is absorbed, glucose is absorbed in proximal tubule. More glucose is distal tubule, delivered to distal tubule, and the collecting term glucose goes into urine. At the same time, the sodium which goes into distal tubule, that or regenerate or activate tubular feedback mechanism or autoregulation. Thereby, they are constricting the afferent artery, and thereby you are just giving less pressure to the glomerular capillaries. So whenever there is less capillary pressure, the filtration will be less, proteinuria will be less, and that is the fundamental principle of action of these drugs, which prevent or reduce the relative risk of nephropathy. And at the same time, let me say, on the other hand, efferent arteriole, there is a two drugs, renin-angiotensin mechanism. So if we use renin-angiotensin, either ACE inhibitor, receptor blocker, that will dilate the afferent artery, and thereby they'll reduce the interglomerular pressure. So when these two drugs is used together, then kidney is safe. So proteinuria will be less, albuminuria will be less, and the protection is there. And that is the mechanism of action, how the kidney is safe from these drugs. Now coming, how it acts, you know, the glucose is less absorbed, it is going down to the urine, so less blood sugar is down. At the same time, water diuresis and sodium is diuresis, blood pressure is less, weight is also less. So it is a good classical drug. Now, how they prove, as is rightly said, Shahjada, that EMPA, REG means removing excess glucose study. This study has two aims. First aim, cardiovascular, and second aim, renal protection. Both has cardiovascular and renal protection. In fact, 1980, FDA approved, if we have to use their drug after metformin, this is the drug sodium glucose transfer. So combination drug will have dual effect, as you know. Now, what is the target of this study? Target in terms of three things in case of cardiovascular and three things in case of renal. Cardiovascular, what are the three important things? To reduce the MAC, major adverse cardiac event. What is that? Other to reduce this, what is non-fatal stroke, non-fatal myocardial infarction, and other serious effect, and also the cardiac cause of death. And what is the nephropathy in case of diabetic reduction? Relative reduction is, as already said, 48% or 44% relative risk reduction with this drug in nephropathy. Reduce the diabetic nephropathy. In terms of what? In terms of progressing to macroalbuminuria, progressing double the serum creatinine level, or initiation of the renal replacement therapy, or the death from cardio. As you know, most of the renal patients die due to cardiovascular problem, and rather than renal before reaching the end-stage renal. As rightly says, all the study is done in established cardiovascular disease. Rightly said, Professor Shahjat Salim, all have cardiovascular. So it is a very good drug, can be used. But remember, once you use this drug, as I said, initially there is a drop of GFR. So initially there will be drop of GFR and creatine will be raised. But after 4 weeks, it is established and it will be persistently remain low. Now the question, how much renal impairment you can use drugs? Initially it was 45 ml. Now they accepted it that up to 30 ml GFR, you can use these drugs. At the same time, as you know, metformin can be used, and if the GFR is less than 30, it is better to avoid because of metabolic lactic acidosis. But nowadays they say how much case you have given lactic acidosis for this metformin. So these two combination is an excellent combination in my regards, and these two drugs is metformin is the first drug of choice, except there is a intolerance, other side effect, and sodium glucose transporter is a very good drug, except severe renal failure, as I said. Only the side effect, sometimes it may cause hypotension, and sometimes it may cause some problem. But you remember one thing, I have seen some of the patients, blood sugar is controlled, but in urine you can see 3+ for glucose. So nothing to be worried, because the blood sugar is passing through the urine. So you have to understand this point. Clinical point of view, I just, those who are students and they can understand this very well. So this drugs is a very good, only you have to see the renal impairment and use iPod. Sometimes they say the genital infection rather the UTI. Sometimes genital infection is the side effect, but sometimes I see some of the patient has urinary tract infection to some extent. So you have to handle it carefully. So these two combination is a very good drug. So I say this seminar is excellent one, and I highlight because diabetes is a disease that causes cardiovascular and that causes renal impairment. And the three main factors is a metabolic factor and this inflammatory factor and hemodynamic factors. These three is well maintained. Not only that, sodium glucose co-transporter has a increase the HIV, which is called HIV, so that there is a oxygen consumption is high, that renal table. It also has reduced the weight, and also it has other effect in uric acid. It lowers the uric acid level. For all this reason, I think this is a very good drug nowadays, and we are using it in combination with other drugs. So it is a excellent opportunity for us to discuss on these drugs, and a very good combination. I do not want to take much of time. Maybe some question we can answer with this, with the chairperson. Thank you very much.
Thank you very much, Shamim, for your excellent presentation and discussion, your comment. Thank you very much. Now I request Dr. Shahjada Salim, if there is any question, please read out the question and answer.
We have some questions from the audience. Can we start, sir?
Yes, please.
So although most of the questions are covered by our respective panelists, so our first question from the audience is, should we be more cautious about starting an SGLT2 inhibitor if the patient has uncontrolled type 2 diabetes for a long period? Like if the patient pancreatic beta cells are likely to have died and there is a risk of diabetic ketoacidosis. So in this case, what should be done?
Sir, as the patient is having blood sugar at a high level, the straightforward approach is that if the patient is having HbA1c more than 10%, for those patients, there should be initiation of insulin. Even the patient is having HbA1c lower than that, but the patient were on OADs for many years. Now it is agreed that if the patient is having on 3 or more non-insulin drugs and HbA1c more than 7.5%, the patient should also be initiated with insulin. So if the patient is having high blood sugar without insulin, after starting any of the SGLT2 inhibitor, we may invite diabetic ketoacidosis. So if we start empagliflozin or dapagliflozin or canagliflozin in those patients, there should be at the same time insulin should be started. Otherwise, catastrophe is waiting for the patient. But if the patient is having HbA1c lower than that, or patient is newly detected HbA1c 8%, 8.5 or 9%, for those patients, empagliflozin alone or empagliflozin or metformin combination is the most preferred option. And again, I showed that according to American Diabetes Association, the patients who are having high risk of cardiovascular events, or patient has established cardiovascular events, or the patient is overweight or obese, for those patients, empagliflozin metformin combination is suitable one to start with.
Our next question from the audience is, would we consider withholding SGLT2 inhibitor in acute kidney injury or any acute emergency? So I'm requesting Professor Dr. Shamim Ahmed sir for this.
You see, in acute cases, as a mechanism action, it will reduce the GFR. So there will be initially there will be creatine rise. So in that cases, acute cases, it is better to omit. Then when this acute case is overcome, then you use it, because otherwise creatine will be raised. So that is a teaching that you should not use an acute case, because you cannot differentiate whether it is progressing to high creatine level after using it. So it is better not to avoid, not to use.
Sir, we have got another question. What diabetic medications can be used when eGFR is less than 30 ml per minute per 1.73 meters?
We have said that is the cutoff point we use 30 ml per minute. Above that we have used, below that it is better not to avoid use it. Initially, it was 45 or 40, but now the allowed is up to 30. So this has been increased in terms of eGFR.
Thank you, sir.
Recent study shows like that.
Our next question is, among all SGLT2 inhibitor, which one is superior regarding cardiovascular safety or renal outcomes?
আমি একটা দেব?
Yes, Professor Shahzad.
Thank you, sir.
Yeah,
Considering the effects, all SGLT2 inhibitors are almost similar. But if we consider to the evidence, this has been achieved by the good conducted studies. I have shown the comparison of several SGLT2 inhibitors in several outcomes. In total, empagliflozin is the superior one. But if we compare for the reduced ejection factor heart failure cases, empagliflozin and dapagliflozin have the evidence, canagliflozin did not have. If we consider the weight reduction, the empagliflozin has the moderate weight reduction, but canagliflozin has more than the empagliflozin or dapagliflozin. If we consider the preservation of the renal function, in that case, we have the study with the empagliflozin and canagliflozin. So, segregating the patient's condition, we can choose anyone, but overall, empagliflozin is in a better position to select for almost all patients with type 2 diabetes mellitus.
Yes, I do agree with you that empagliflozin is better. Because canvas studies show there is no change in albuminuria, but in case of empagliflozin, they reduce this reduction of albuminuria. So empagliflozin is better compared with canagliflozin. The canvas study has shown like that.
Thank you, sir. Another audience asked about, are there any contraindications to starting these new meds immediately post-MI? Is metformin still contraindicated immediately post-MI?
The question is not clear. Can you repeat it? Because of your network disturbance.
Okay. Yeah, Dr. Sadia, yeah, I got it. Yeah, I can, Dr. Sadia, yeah, I can read it from the Q&A. The question is that, can we start this SGLT2 inhibitor immediate after acute MI? For patients with acute MI, if the patient were on OAD and had good glycemic control, even in those cases, it is better to start insulin. And for MI patient, it is better to continue insulin for at least 6 months. After that, we can start. There is no contraindication or indication regarding starting empagliflozin or other SGLT2 inhibitors immediate after acute MI. But we should not do any hurried approach. We can wait.
I think we can answer this question in other way around. In any acute emergency, whatever condition it may be, we should be careful, and insulin is the best option at that time. After settlement of the emergency, we can go back to whatever medication patient can tolerate. In case of any emergency, no option to try a new medication. Only the safest medication at that time is insulin. I think lots of questions have been asked. Now it is already 9:30. We shouldn't continue anymore.
Sir, we have got lots of questions. So can I continue 2 or 3 questions? Can I take?
But it will take an unlimited time, huh? Quickly, 1 or 2 questions.
As depletes volume of the body, is it safe for the patient who already taken diuretics or those who are underweight?
Can I answer this question?
Yeah, I got
Let me say it is found in the study, even with this sodium glucose transporter, they can use these diuretics. Only thing that you have to use the diuretics long before the drugs. If you use it at 6 o'clock, you use it at 9 o'clock, so that there will be no interaction in sodium glucose transport pathway. So it is safe, but you have to be careful regarding this hypovolemia. And at the same time, the sodium glucose transporter, as I said, hyperkalemia and this acute renal failure, This should be what is found in the placebo group and the control group, this study group. It is better that in terms of hyperkalemia and acute renal failure, Empagliflozin study shows that is reduction in that this group. In case of this study group, this is better than placebo group. So you can use it safely. Safety measure. Only thing you have to use in the different time. Thank you.
Sir.
Am I right, Professor Shahzad Chaudhary?
Rightly you have said. Another part of the question is that in the patient with normal weight or underweight, it is one of the important drugs next to GLP-1 receptor agonist to reduce body weight in the patient with type 2 diabetes mellitus. But if the patient is having standard weight or underweight, there is no contraindication. We can simply use the drug.
Sir, can SGLT2 inhibitor can be given in the fasting month of Ramadan?
We had several concerns, but the current statement is that during the Ramadan, we should not start the drugs. It is safe to start at least 4 weeks prior to Ramadan. So if the patient is having the diagnosis of type 2 diabetes mellitus immediate before Ramadan, we are not going to start. But the patient who are receiving SGLT2 inhibitor in the full dose, even 25 milligram of empagliflozin, we can continue this drug, and this drug should be taken during the iftar time.
Okay, now I'm taking the last question. Can empagliflozin be used as monotherapy if metformin is not tolerated by the patient?
It is also important question, I should say. At least 6% of the patients in our country cannot tolerate metformin, and there are adversity found in 10 to 12% of patients. So many of the patients cannot tolerate. In those groups, we should try to use any of the insulin sensitizers. So next to metformin, we have 5-glitazone in use. So we can try 5-glitazone. Because for type 2 diabetes mellitus, Zafar Ahmed Lutif sir frequently said that why are not using insulin sensitizers? This should be cleared. Because the pathophysiology is that in type 2 diabetes mellitus, the insulin secretory defect is there on the background of insulin resistance. So we have to address insulin resistance. Otherwise, there will be increased chances of cardiovascular diseases. But if the patient is having heart failure or increased potentiality of any malignancy, we cannot use 5-glitazone. For those patients, we can consider. Otherwise, we have to select 5-glitazone if patient cannot tolerate metformin. If the patient cannot tolerate both of the sensitizer, we can, for those patients only, we can also given.
Salim, you are in network problem. Let me add with it. Yes, FDA has given this approval in case of established cardiovascular disease or a diabetic. You can use this drug as a first choice. There is FDA has given 2018. This approval is already given. Yes.
Okay, thank you very much, sir. Our respective panelists and chairperson, sir, for a very.
I think time is up. Session. I think chairman will say something more.
Okay, now I'd like to invite Mr. Jahiduddin Chaudhary, National Sales Manager, General Pharmaceuticals Limited, for the vote of thanks.
Thank you very much. Honorable Chairperson of today's live webinar program, Empagliflozin Metformin fixed dose combination, which is the new horizon in type 2 diabetes mellitus. Professor Dr. Jafar Latif sir, the former Honorable Director General of BARDEM, learned keynote speaker of today's program, Dr. Shahzada Selim, Associate Professor, Department of Endocrinology and Metabolism, PSMI. Respected panel of experts, Professor Dr. A.K.M. Mohibullah sir, who is the ex-director of NICBD, President Bangladesh Cardiac Society and Vice President APSC. Professor Dr. Shami Mohammed sir, renowned nephrologist of Bangladesh, who is the ex-director of NICDU. Professor Dr. Khan Abul Kalam Azad sir, the legendary medicine specialist of Bangladesh, the ex-principal and professor Dhaka Medical College. Respected all other dignitaries and distinguished participants on Zoom platform as well as live Facebook page. Very good evening and assalamu alaikum. On behalf of myself and General Pharma Management, I would like to pay my heartfelt thanks and gratitude to all of you for your patient sharing and your cordial participation. This program makes successful one which will be inspired us to arrange such program in the coming days. Dear sir, all you know that as quality is the first priority of General Pharma, every step of manufacturing procedure we maintain very strictly and collect all the raw materials from best sources of the world. Which continuation of today's discussed generic empagliflozin. General Pharma is the only company of Bangladesh who are using Poland, whole pharma raw materials of Poland. And this General Pharma using their brand Empagliflozin M in European empagliflozin. As a result, with the affordable cost for your patients. As a result, we have achieved your trust and confidence on our product, which is the great strength for us. General Pharma, due to quality of each product at present, exporting their medicine 30 countries of the world. Here I can assure that the standard and quality of product we are exporting various part of the world. The same standard and quality product we are offering domestic patients, that is for your patients. We firmly believe that beyond your support, a pharma company we never can move forward. So, sir, from my core of heart, I would like to request, please keep continue your support in favor of our General Pharma quality product, especially on today's discussed product, our Empagliflozin and Empagliflozin M. We are very much thankful and grateful to the chairperson and panel of guests for your valuable time as well as valuable comments. And speakers, Dr. Shahzada Selim sir, for his brilliant presentation. Always, General Pharma always beside of you with the best possible professional service, and please keep continue your support in favor of general quality product. Stay safe, you and your family. Thank you very much again. Assalamu alaikum. Allah Hafiz.
Dear audience, we are at the very end of today's session. May now request our Honorable Chairperson, Professor Dr. Jafar Latif sir, for his concluding remarks and closing the session.
First of all, I'd like to thank Messrs. General Pharma for organizing this beautiful scientific session on metformin empagliflozin combination therapy. Before giving any concluding remark, I'd like to express my sympathy to the families and also pray for the departed soul of our colleagues who are lost their life during this pandemic situation. And also pray early recovery of all my colleagues and friends who are still suffering in the health sector services. And I wish them early recovery. And I wish all other colleagues be safe in this situation that we are now encountering. Now then, I would like to express my thanks to my friends and colleagues who spoke in this occasion. My student, our presentation, A.K. Mohibullah, cardiologist, Khan Abul Kalam Azhar, very good person. I love him personally very much. And Dr. Shamim Ahmed, I know him. Lastly, I want to say regarding one thing regarding this medication, which you'll have to remember. Dr. Shahzada Salim asked about the side effects of the medication of empagliflozin. One of the things is the recurrent UTI, candidiasis, all this thing. Usually, females are usually suffering more. But I can assure you that as we are using wet hygiene, not like that of dry hygiene of the Western society, the prevalence of this sort of UTI or this sort of things would be less in our country because we use wet hygiene. That is very important. Last of all, which medication is best? No medication is best, no medication is worst. We can have to remember 5 important points whenever we prescribe medication. I say, first of all, we shall have to consider the age of the patient and what age, what type of patient. Then we shall have to think of associated condition of the patient. CKD, stages of CKD, any other acute complication, pregnancy, low weight, low body weight, definitely those who are losing weight, body weight, we are not going to prescribe this sort of medication. Considering all this aspect, as a physician, as a clinician, we should be the best judge to prescribe the right medication to our patient so they can be benefited. So considering all these things, we should think of the thing that then we shall have to prescribe to our patient. Thank you very much, organizer, for asking me to chair this particular session. Thank you all. I wish that all of us will be healthy and be safe, and Allah will grant us, will be very merciful upon us. Thank you very much.
Thank you very much, sir, for your valuable opinion. Now, I'd like to convey our heartiest thanks on behalf of General Pharmaceuticals Limited for being with us in this program. So thank you once again, and goodbye. Stay safe. Thank you.